At this moment in time, we'd like to bring you now the first topic, sinus. Now, everyone has it, right? Now, most of my friends have it, I have it. So, what can we do about it? Today, we have for you Dr. David Chin to help you understand the common nasal and sinus conditions. And Dr. Chin will also share when to seek medical care and the treatment options available. Now, first and foremost, this man here, Dr. David Chin, is an ENT head and neck surgeon with a subspecialty focus in rhinology, endoscopic sinus surgery, and endoscopic scalp-based surgery. Now, he did his post-specialist training with the Sydney Clinical Rhinology Fellowship, and subsequently, he served as a consultant at Changi General Hospital, where he initiated and headed the rhinology service from 2014 to 2016. We're going to learn so much from him. Ladies and gentlemen, Dr. David Chin.
Thank you very much, James, for that kind introduction. So I'm very happy to have everyone listening today because I'm very passionate about this topic of sinus. Every one of us probably has experienced someone, either yourself or your family member, who has a sinus problem, and I'd like to get into that. And even I have a sinus problem. So I've experienced pretty much most of the symptoms that you might be wondering about. So I just sell Koyo a little bit. I come from a clinic. I don't work alone. We have 6 ENT doctors, and I'm one of the specialists who deals with nose and sinus issues. So if you're wondering how often do we have sinus, I want to define that. For most of us, sinus actually is allergic rhinitis. Some of us know that we might be allergic to dust mites, for example. And it is estimated, based on official records, that in the 1990s, it was at least 10% of the population had it. In 2000s, it was 13%. I think more recent data suggests that it could be about 20 to 25% of people who have allergic rhinitis symptoms. So I'd like to just bring us up to speed what sinus or allergic rhinitis is, because a lot of patients come to see us and they may have an upper respiratory infection, they may actually have sinusitis, they may have some other reasons for having these symptoms. But when you have a nasal obstruction gradually building up, when you wake up in the morning, you get a runny nose, and it's clear, cloudy mucus, you get sneezing, itching, sometimes an itchy eye as well. And this happens every single day. You sort of get used to it. You most likely have allergic rhinitis. And the difference between this and an upper respiratory infection is typically when people get sick, and most of us, all of us have had viral infection. You tend to feel down, you've got aches, it lasts the whole day, you've got a sore throat. That's very, very different from the usual pattern for people who have allergic rhinitis. And most of us will know, patients that come to see us will most often have already taken antihistamines off the shelf. They mentioned Zyrtec, Telfast, Claritine. These things are all familiar to you. And they work, and they often say, but I take it, I get better, and when I stop, the symptoms come back. And so they come to us thinking that they have a sinus problem. Today, I want to just touch on the fact that actually, if we understand an allergy as not like an infection, it's going to be there all the time unless you're using something to suppress that. So you don't get cured that easily. Now, for instance, if you have high blood pressure and you don't take your medications, then you're going to have the high blood pressure. So you're sort of dependent on that. But there are ways to treat this more effectively. So our guidelines say that if you're getting your allergy symptoms more than 3 days a week, almost every day, which is quite common in our part of the world because we don't have seasons, right? Then you're much better off using a nasal steroid spray. Now, when I mention the word steroid, some people will get a little bit anxious. I'll come to that later. No, it's better to actually be on a regular medication that controls your symptoms rather than wait for it to come. Symptoms come and you keep chasing those symptoms. However, for allergies, actually, there are opportunities to have a cure. And I think for patients who have a long trajectory, if you're a child and you've got allergy at age 6 or 7, and if you're going to control your allergy for the next 30 years with nasal steroid sprays, then we should have a better option to treating that. I will come to that as well. There are options in treating with immunotherapy. So I mentioned just now steroids. So one of the mainstays of allergy treatment is actually using nasal steroid sprays. And people will invariably ask us, but steroids not safe to be used long-term, right? Well, the truth is, the amount of dose that comes in the spray is so small that a minuscule amount of that gets absorbed into the system. Now, I'm just showing you these example graphs that, if you're giving a typical dose of 55 micrograms, if you can understand what a microgram is, in patients 2 hours after dosing, the amount that have less than 10 picograms, that's like 1 million times less, I think, than the amount that you spray, is about 90%. So it's a really small amount. And the other thing that we all know about steroids is that if you take that as a tablet, if you get that, we call that systemic because it's going through your system. So when you take a tablet of steroids, it's going through to where you want it as much as it's going to your big toe, for example. So if we look at patients who take steroids for long term, for example, to suppress rheumatoid arthritis or lupus or chronic inflammatory diseases like that, then of course there will be an upset of that balance in the body system. But when we use the nasal steroid spray, actually there is no change. And I just showed this graph on the right side that shows 6 weeks after using it on a regular basis, there is absolutely no change in our body's own steroid levels because that minute amount doesn't really affect that axis of control. The other thing that people have is that they've used steroids for dermatitis and they say, okay, maybe the skin gets a bit thinner, and that does not happen in the lining of the nose or the sinuses because the anatomy is completely different. So that doesn't exist. It's one of the two myths that I need to clarify for most patients coming to see us. So it is safe. I mean, bottom line, it is safe. And in Singapore, most of the nasal steroids are approved based on the FDA, American guidelines, from age 2 years old and onwards. And the reality is that most patients that are less than 4 don't really need to use nasal steroids. Allergy usually starts about age 4 or 5 at the earliest. So how do we diagnose beyond the symptoms? If you want to know, you can do an allergy test. It can be a blood test. It can be a skin prick test. This is the most common way we diagnose. And in this picture here, you can see the various allergy tests being done on the skin, and we wait 15 to 20 minutes and measure. So you can see the one at the top right corner, it's really, really angry and swollen. So that's probably one of the allergens that this patient is allergic to. And in Singapore, actually, if you just throw a coin, actually, it's maybe 80% of patients you can guess will be allergic to dust mites. The thing is that we have a tropical season. We don't have seasons, spring and all that. So our biggest culprit here are dust mites. Occasionally, we get patients who have other allergies as well, but by far it is dust mites. So the thing about dust mites is that the 80% of patients that you pick just randomly will be allergic to dust mites. The interesting thing is that if you are negative to dust mites on allergy test, then you're very unlikely to be allergic to other allergens as well. These are the allergens that we commonly test for. So we don't actually, some patients look at these pictures and they're actually very, very worried about it. But we're only using a protein that comes from these allergy sources to test. And it's a pretty painless way to test. It's just it's not a true needle. It doesn't draw any blood. The most that people experience, if they are allergics, they get a very itchy spot, just like a mosquito bite. So I mentioned earlier that this is one of the conditions where we actually have an opportunity to cure. And this is just, to my patients, I explain this. They say, is my immune system weak? No, it's not weak. It's actually overreacting to something that is actually harmless to us, these dust mites, for example. So can we train our body to not overreact? Yes, there's a way, and it's called immunotherapy. In some parts of the world, historically, it was delivered by injections into the skin, but that's a very tedious process. And for nasal allergies, we can actually use what we call sublingual immunotherapy, where we spray it under the tongue. And if we do that for a period of 2 to 3 years, then we then have a chance of changing the way our body responds to the allergen. And over time, the body then recognizes this is something that's not dangerous and it doesn't have to mount the full response. So when we move from medications, which I mentioned earlier, you could use antihistamines if you only get sneezing once or twice a week, nasal steroid sprays on a regular basis if you're getting more chronic symptoms. And if you're going for a cure, especially for kids and younger patients, then maybe immunotherapy. But then sometimes we do need to have surgery. And the main reason is that one of the symptoms of allergy is a nasal obstruction. So we can get a blocked nose largely because this structure in the nose, if you look inside your nose, you flare your nostrils, and you look hard enough, you'll see these two lumps at the side. Some people think they're polyps, but they're not. What you see, it's the inferior turbinate. It's called a turbinate. This tissue actually swells up when it's inflamed, just like when we get a flu. And if you have chronic allergy for many years, it gets bigger and bigger, just like you go to a gym and the muscle gets bigger. So you have to do something to unblock the nose. And we can do various different techniques to make that structure small again so that you can breathe freely. So an example of this, one of the types of turbinate operations that I prefer to do is actually to remove not just the excess tissue that has grown over the years, but actually remove the bone that underlies this structure, because it gives a more lasting result. So you can see at 3 weeks, almost everything is healed back. Patient breathes much better. And the reason why I prefer this option to other options, for example, it's because if the patient then feels good and does not continue taking the medications, it is highly likely that the allergy will continue. In a few years' time, the lining could become swollen again. So by doing something that is at the same time aggressive in removing excess tissue but still retaining some of the lining of the nose, we can allow patients to have even if they don't continue using medications when they're supposed to, they still have a clear nose for the long term. Now, there are other symptoms. Some patients may then say, but I also have a runny nose, and I've done surgery, and I can breathe better. What am I going to do with my runny nose? I still don't want to be on antihistamines forever. I don't want to be spraying my nose. For these patients then, thankfully, about 7-8 years ago, some clever doctors, scientists in the US came up with a cryo device where you can actually freeze the nerves that stimulate runny nose, and you can disable them, and they can be disabled in the sense that it doesn't trigger a runny nose effectively for 1 to 2 years. So then you may ask, but that's 1 to 2 years. That's for many patients preferable to taking a tablet every single day. If you look at the results here in the initial studies, you can see quickly that within a month, the symptoms of runny nose, itchiness, and irritability of the nose goes down, and it can be sustained for at least a year. There's some studies that go up to 3 years that show still some prolonged effectiveness for some patients. So the bottom line is allergy of the nose, while it can be cured for most patients, if they don't undertake immunotherapy, then they're going to have to control it, just like you control your high blood pressure, just like you control your diabetes. And sometimes there is a need for surgery if your nose is very blocked and medicines don't help. But ongoing treatment then helps to reduce recurrence of symptoms. It also prevents those structures from swelling up and potentially blocking your nose again. And I want to go into what sinus really is, because patients that come to us and mention sinus, by and large, they have allergic rhinitis. But all of us have experienced what a true sinusitis is that you get your viral infection and it spreads into the sinuses. So what are sinuses? I'll show you a picture later on, but essentially the symptoms in words are almost the same. It's a nasal obstruction, sinus congestion, if you will. Then there's a nasal discharge as well, but the difference here is that, and people notice this, it's going to turn green, yellow, sometimes yellowish brown, and that they know, intuitively they know that this means there is a bacterial infection. It's not entirely true, but along those lines. And sometimes you get a pain as well. Sometimes if you've got a very bad sinus infection, it can be painful. And we very often when we have a blocked nose from infections, we find that we can't smell as well. And that's not very typical of allergies. So what are the sinuses? They're actually air spaces within the head. The purpose, they're there for resonance, for our voice, to make our head lighter, we don't actually know. But imagine this, you walk through your nose, which is like the entrance cave, and then at the side you have these little holes that lead into big rooms. And when everything is going perfectly well, the big rooms are 99.9% filled with air, the lining is thin, and everything is working smoothly. It produces mucus, and the mucus transmits out into the nose to our throat, and we don't feel anything. So I put a picture here, an example of a maxillary sinus, where the lining is absolutely quiet, no infection going on. We can't actually see this in a patient unless they've had an operation before. So I picked one where this patient has had an operation before, and this is when it's quiet, there's no infection going on. Now, if you had a viral infection and it doesn't get better quickly enough, the lining swells up in the nose, more mucus is produced, the lining in the sinuses then get swollen too, and then because the mucus is not moving fast enough, you get the opportunity for bacteria to grow. That's what we find in stagnant water as well. And over time, the mucus then changes and you get the discoloration. And here you can see this trail moving down from the exit point of the sinuses to the throat. And there are certain criteria for when we define when someone has got a bacterial sinusitis. And some of them are when you're initially getting better and then you get worse, high fever, pain, and those sorts of things. And patients that come to see us as ENTs will always say, okay, I've had this number of courses for antibiotics and I'm not better. Or obviously, naturally, because they've seen their GPs and they've been treated. So yes, if you look at all studies, if you give antibiotics for sinusitis, you get a better outcome. You get better faster. But on the other hand, some patients are actually more wary these days. They're wondering, how can I be taking antibiotics every time I get flu that I suspect becomes bacterial sinusitis? Can you get better without antibiotics? And actually the answer is yes. So we have this antibiotic conundrum, right? To give or not to give. Some patients are also aware that you can easily get side effects. Some people don't get side effects, so good for them. But if you look into the fine print, every single medication that we take has got a side effect. And some of the more powerful antibiotics that we use, if you look in the fine print, you'll see that there's a risk of, for example, a tendon rupture in 1 in 700. And this could be quite serious, right? If you're taking antibiotic just because your phlegm has turned yellow. And the other question is, do you give it for 3 days, 5 days, 7 days? Who knows? Because there is an average number for a typical person, but it doesn't work for everyone. There are other factors that determine whether your sinus infection gets better or not. And this is no surprise. If you look at the charts for adverse or side effects for taking antibiotics, naturally it always favors not taking antibiotics. If you don't take antibiotics, you can't get side effects. The other thing that we think about, if we're not just thinking about ourselves, we think globally. The more antibiotics we give, the more resistant the bacteria becomes, and we keep having to have stronger and stronger antibiotics. I will come back to this now, that these nasal steroids are not purely for allergies. They are also recommended treatment for sinusitis as well, because they reduce the inflammatory response that causes a lot of our symptoms. So the other thing that I'd like people to understand is that mucus from our sinus and nose doesn't move by gravity. It's not like you're going to, unless you have a lot of it, you don't tilt your head down and the thing's going to just drop out of your nose. It doesn't work like that. It is more like a conveyor belt, like a travelator that you have at Changi Airport. And if everything's working properly, the people move smoothly along, no one notices anything. The moment you have a choke point somewhere, everything backs up, and then it becomes a vicious cycle, right? You know this in traffic jams. Sometimes you're driving, the other side of the road has an accident, your side is fine, and then you realize that you're backed up for 1 kilometer behind, because these things are cumulative. And every sinus has got this flow coming through a tiny, tiny hole for exit point. So you can see in these examples here where the thick mucus is not moving out well. And one of the prime examples that we have as sinus surgeons is that in the past, sometimes with that lower picture on the right, you can see 2 holes there. They're literally 3 millimeters apart. There's a big hole, and we think with a big hole, any amount of pus is going to come out. But we have a phenomenon where patients get prolonged sinusitis because the mucus is coming out through the original hole in front on the left side of that screen, and then it's dropping back into the big hole at the back, so it's going round and round. So you get 90% of the stuff cleared, but some of it still goes on. And so why does this happen? Now, this coronavirus is not the COVID-19 that we talked about. This article was written in 2001, even before SARS. But you can see in even the first few days of any viral infection, that nice carpet of what we call cilia, which are these fine hairs on the surface of the cell that moves mucus along, gets destroyed. And so it's just like a war. The longer you go into a war, the roads get destroyed, bridges get destroyed, and even if you decide like a ceasefire, like what's happening in Iran now, you're not going to build back those bridges in one day, right? That's not going to happen. So how does this manifest? And I think this is really important. A lot of patients come to us saying, oh, I've got better from most things, but I'm still coughing. It's been 1-2 months since I had this infection. No more pain. I don't see any mucus. Nothing's coming out. So there are various ways this mucociliary dysfunction can manifest, right? So you can get a prolonged dry cough after upper respiratory infection, sinusitis. Even sometimes with people with allergies, with their mucus is very sticky, and there's been a lot of chronic damage of this mucociliary transport system, they can get these symptoms as well. So how do the patients describe it? Sometimes it's just sticky. Sometimes it's a feeling that something's at the back of the throat. I can't clear it. Sometimes the patients keep clearing their throat, or kids may be snorting. Or sometimes it may be as subtle as voice breaks. Now, if you take a lot of coffee, sometimes you may experience this as your daily thing. You're speaking halfway, your voice gets lost, and you clear your throat a bit and it clears up. So all these things reflect some form of mucociliary dysfunction. And you will get from your GPs and doctors various kinds of medicines that make mucus less sticky, to put it simply. But some of them do a bit more than that. They actually help that mucus transport to recover. Otherwise, when you have a bigger problem that's been there longer, you might use something, and this is something I highly recommend you try properly. It's not easy to do, but if you start to use a nasal saline irrigation. Now, some patients think, how could I possibly do that? That's what I first thought at first. I was telling patients about this theoretically until I started using it myself, and then I loved it. Essentially what you're doing, you're not trying to take a spray gun to move things along. You're actually irrigating it, and you know that if you have think about a river. If the river always has smooth flow of water, it looks clean, right? So, and this is what we try to help when we're trying to help mucociliary transport when it is not working well. When you're well, you don't have to do it. When you're recovering from sinusitis or in the midst of a sinusitis, you want to do it. The thing is that why does it not always work? It's because I mentioned earlier that the openings to the sinuses are very small, about 1-2 millimeters when things are normal. So can you imagine when it's swollen to be even smaller? So whatever we wash and spray on our nose never ever gets into the sinus unless you've had a sinus operation before, like the picture that I showed earlier. But it still helps because it removes the clog in the small junctional point. So at least if that junction is not clogged up, then there's a chance for something to come out. If the junction is clogged up, there's no chance at all. I just want to briefly mention another type of sinusitis, which is an entirely different disease now we understand after research in the last 20, 30 years. So look at the mucus on the left picture where it's just this thick pus kind of stuff. On the right side, it looks more like engine oil or honey or something like that. It's super sticky, right? That's different. We recognize that as manifested in nasal polyps, which are basically super swollen lining of the sinuses and the nose. And the whole clinical picture is different. And we can see if we look at the cells. Now, in the past, we just described it as sinusitis, chronic sinusitis with polyps. But now if we look at the cells, we look further, we can see that the cell types are different. There's a certain type of cell called an eosinophil that defines a lot of the processes that happen. I don't want to go into too much in detail, but over time they've looked at the kind of chemical messengers that are involved in that sort of inflammation, and it's entirely different as well. We call this type 2 inflammation. So briefly, if you have chronic sinusitis, what this means is that our definition is that you've had it for 3 months or more. It doesn't mean it has to be exactly 3 months, it could be 10 weeks, whatever it is. The whole reason for the sinusitis persisting is no longer just blocked, no longer just a type of bacteria, but a whole dysfunction of the lining of the sinuses. And look at the yellow box here. The guidelines from the most respected body in the world says that in this situation, you use saline washes, you use intranasal steroid sprays, that's what INCA is. You avoid antibiotics. And so patients would think intuitively, oh, if I got infection, I should be taking antibiotics. But clearly, the guidelines, based on a lot of evidence from studies, says avoid antibiotics, right? But then steroids work in this condition. I can show you this chart. When you see that diamond far to the left, it shows that it reduces symptoms when you use steroid sprays. And use it for longer, it helps. I mean, oral steroids, right? They definitely work. Patients know it works better, except that they know that there are very, very severe long-term complications and side effects, and even short-term side effects there are. So you can't keep using oral steroids even though they work. And it's counterintuitive, for you know that steroids actually suppress the immune system. So this is not a question about the immune system being weak, but it's a question of the immune system not being regulated properly. You've got an army that you're just throwing around and shooting everybody in the way, right? So that's what's happening. So don't use antibiotics. Try to use sprays. We call this topical steroids because it's not going through the system, the rest of your body. And we find, in studies show that if you wash it, it's more effective than drops, which are more effective than sprays. The sprays that I mentioned earlier on are actually designed for allergy of the nose. So they just reach the lining of the nose. They get nowhere close to the sinuses. That still helps. And the key, again, is because the opening is very small. So if you do have sinus surgery and you open that hole from the 1 millimeter to 5 to 10, you obviously get the 50, 100 times more effectiveness. So I have to mention sinus surgery because at some stage, some patients will need this. We call it FES because unlike other operations where we just cut things out, We put the term there functional because we want to say that we try to maintain as much of the lining as we can, because without the lining, the sinus will never function. So if you look at this video here, we're looking at the patient's right side. I hope this doesn't alarm anyone. But this is a very complete sinus surgery where we've joined up the 3 main sinuses into one big cavity. This is now looking underneath the maxillary sinus under the eye. It is smooth, it is clear. And the reason why we need to do it for patients like this is because in nasal polyps, if you leave any little corners there, it allows the polyps to start growing again. It allows mucus to build up, and you can't control it with the washers that you want to use. So this is a patient who has had what we call a full house sinus operation, where it's totally open on both sides. We have heard in the past, and sometimes still, this very sexy thing of balloon sinuplasty, very, very minimally invasive. I have used it on occasion, but I think that if you have the ability to do a very wide sinus surgery with no additional risk, like the picture I showed earlier, that is preferable. Because with a balloon, you get the maximum size of maybe 4 millimeters going through all of that. I think the only role for it is for perhaps patients who have a reason why they can't have a full operation. There are some patients who are on antiplatelets for the heart, for example, or if the only one sinus is affected, and we need to do that. So a balloon basically just opens up that particular sinus. And some patients, they can even have operation where you open it so wide. Now you can see this patient. This is the left side. That is the center. Behind that's the brain. And those are the structures that we need to be careful about when we operate. But you do it with care. Everything works out fine. You can wash this nose. This nose can work with gravity alone, at least this part of the nose. And we have to get our patients to wash our nose. And this is mainly for patients with polyps, because they need to do this as an ongoing treatment for a long time. But it's techniques that even people who get the acute sinusitis, like you and me, from time to time can use it for 2-3 weeks. Now, just to say, what was the point of learning all about the inflammatory markers, what messengers there were in the cells? Well, for some patients with nasal polyps, no matter what we did, we couldn't control it. And a lot of patients know this, I got polyps, it's never going to get cured. But thankfully, with the advance of science and research, in the last 15 years and in sinus, you've got these things called biologics. So they're basically antibodies that are specifically targeted for messengers in this pathway. And if you can block the messenger, you can block a lot of that. So we have various ones. I won't go into the fine detail of what they're blocking, but I want to show you this chart that people have worked out the whole pathways, and they can make blockers to block what's happening. And it has been shown in studies that you can improve symptom scores, you can make polyps stay away. I mean, if you stop using the medication, you can see that over time it will recur. But that's far better than having to go through 5-10 surgeries in some cases, or having a nose that's always blocked with thick mucus and you can't smell. So I was very happy with this gentleman. I can show it because it came up in the newspaper. He was the first patient that, as far as I know, had these biologics used to try to control his nasal polyps after having the most extensive surgery that we could dream of. And I went through him with the first generation ones. It worked, but wasn't that great. And second generation one has been a life changer for this gentleman, where he used to have to take steroids every few months. And so he's quite a small bone guy, so we don't want him to be at further risk of osteoporosis and all that. So now I've got to go into something else. If you don't have a sinus problem, the other thing that's becoming an epidemic in Singapore is snoring and sleep apnea. And everyone's talking about it more and more. Our physician colleagues, cardiologists are sending patients to us because we now recognize that a lot of the side effects of sleep apnea relate to the cardiovascular system. So what's this? Obstructive sleep apnea. So basically, it's a period of time when you're asleep, of course, where the air flow is diminished or you don't get any airflow at all. It's blocked. Airway is blocked. And the reason that happens is because when you're sleeping, you're lying down, there's no muscle tone, everything just falls back and flops away. So you may then have this kind of situation. You can see in this animation that you've got breathing, and then suddenly they go flatline there. It's basically no air is going on. But the effort to breathe increases and increases. The person is struggling as his oxygen drops. You can see the lowest chart there, that's the oxygen dropping. And then at some stage, there'll be such a strong trigger to wake and the sleep gets disrupted. And they go through this cycle tens, hundreds of times a night, depending on how severe it is. I just want to be brief about this. It is very important. Every one of us, I am sure, either has a chance of getting it or has a family member who has it. Every home definitely has got one person affected by this. And in the early case, it may just be snoring upsets the wife. It's noisy. But no, if you leave it there for 10 years, you end up getting hypertension. You leave it there for 20 years, you end up having a higher chance of getting heart disease. If you leave it there for 30 years, you have a higher chance of getting strokes, vascular dementia, the whole list of things. And the earliest sign for some of us is that this thing about our blood pressure. So, our normal blood pressure is supposed to be 120/80. That's what the textbook says. So a lot of people think about, 120 is the number to look at, and 140, they're worried. But sometimes you may want to pay attention to the lower number. What if it's sitting at 85? Is that normal? If you're sitting at 85 and you just got up in the morning, that is not normal. That's a sign that your body's under stress at night already. The cardiovascular system is working harder. There are various explanations for that. I won't go into that. But that's something to look out for. But if you really want to quantify this, we have a thing called a polysomnography, which is a big word for a sleep study where we measure breathing, oxygen, the heart rate, what stage of sleep a person is going to, oxygen, that sort of thing. And you can put a whole graph together like we were kind of showing you in the animation early on. Some people now are going for portable studies where you just wear a little ring or something on your hand and you can get a pretty accurate diagnosis. And especially because if you had to have everyone going to have the full study, with the number of patients that we suspect might be affected by this, there could be long delays in getting your test done. So you can ask further about this. Now, why am I talking about this? Sleep apnea is a whole subject in itself, and I can't talk about it. But because I'm focused on the nose, I will want to emphasize that when we sleep, there is only one correct way of breathing, and that's through your nose. And so why is that? I mean, when we go and exercise, right now, I open my mouth, I get a quick breath in, and I'm much better off. The difference is that when you are asleep, the muscles are all fully relaxed, especially when you're in REM sleep. Rapid eye movement is when you're dreaming. Your whole body is essentially paralyzed except for the eyes. And so what happens then? Your throat then collapses down because you're lying down. The tongue drops backward. And we can see this in a very, very old study here. Look, on the left side of the graph, the two charts when you're awake. Whether you use your nose or the mouth, there's hardly any difference in the upper airway resistance. But when you are asleep, looking at the nasal breathing versus the oral breathing, you can see that when you breathe through the mouth, even though the mouth is much bigger, you then get a higher resistance. It's really harder to breathe with the mouth open, and it's not natural. It's not the way we should. Obviously, when you lie on your back, which is what most of us prefer, things get worse because the tongue falls more easily backwards. Now then, it's not just a matter of treating it when you're an adult and you've got high blood pressure. Now you've got to think about your next generation as well. Our jaw is basically growing when our teeth are growing, somewhere between age 5 and 14 roughly. And if you do not breathe through the nose, then it's not going to function very well, and the jaw bones don't grow properly as well. That means not enough space for the teeth. And so that there's another meaning to that saying, if you don't use it, you will lose it. And then you end up getting a whole feature of a certain thing we call an adenoid face, and the teeth are all crooked. And even if this person goes on to have braces, remove teeth, later on teeth look perfectly straight, they still have a small jaw, so they're going to go into adult life with a small jaw. And if they can remain at BMI 17 forever, maybe they'll be fine. But if they can't, at some stage, they're going to get sleep apnea, or they're going to be a higher risk. And even more thing, we compare, the studies have shown that oriental faces like mine, compared to a Caucasian face, is a higher risk. You've got a flatter face. So I come back to this picture again just to show you the turbinate that I started with when we talked about allergy. A normal turbinate on the left side, you can see a pathway right to the back of the nose. If you've had allergy for a long time, your turbinate has gone to the gym for 5 years, it's going to look big like this, like the biceps, right? And no matter what you spray into this nose, it's not going to get smaller. But there are sometimes other reasons. A lot of people are aware of the nasal septum and that can be deviated. And sometimes the cartilage is bent right from the start of the nose and the gateway is closed. In children, this is important from around age 4 years old until about 10. They have a structure called, we all have this, but in us, in adults, it's smaller. It's an adenoid. It's the same tissue as the tonsils. It's essentially lymphoid tissue, and it can get big, and it can block the nose. So in children, this could be a problem. And it makes it very easy to resolve in children as well. If you take the adenoids out, if that's the only reason the snoring is resolved. So just running through the principles of management of obstructive sleep apnea here. So we want to consider all the factors that might be contributing. Think about things that are correctable. For example, if the patient's got early rhinitis and you can spray the nose into breathing clearly again, that's something you can do. You can correct it. It's always good to be on the slimmer side and losing weight. And that's part of the problem with people increasing in age. Apart from muscle tone getting lax, the unwanted tissue is also getting bigger, even around the throat and in the neck. In the same way, just quickly, like you can go to the gym to build up your muscle tone, you can do the same thing for the muscles of the throat, the mouth, and the tongue, and it's called myofunctional therapy. Otherwise, if you skipped all that, most people will realize, oh, if I've got sleep apnea, I'm going to be putting myself on this machine, right? That's called CPAP or BiPAP, positive airway pressure. Essentially, the machine blows air at a certain pressure, so it prevents the collapsible tissues of the throat from closing up. And then if we have to do surgery, we have to optimize the nose by clearing the big turbinates, adenoids, maybe tonsils. That all relates to that nasal airway that goes from the nose behind the soft palate and down into the voice box. And then there are other kinds of more increasingly aggressive surgical options that can be done. So CPAP therapy, I sort of mentioned this, you put a mask on or a pillow and it blows air at a certain pressure and it prevents that floppy part of your soft palate or tongue from dropping back. For some patients, mild to moderate sleep apnea, sometimes you can actually get these customized oral devices, mandibular advancement devices. You fit them in, it just fits perfectly if you get a custom-made one, and it pulls the tongue forward and pulls the jaw forward, and that could be sometimes preferable to having the machine, a whole contraption. So I'll go back to the nose now. So even if and it's true again, just like nasal polyps, you cannot easily cure obstructive sleep apnea because there are so many factors, right? The person could have big tonsils, that's easy, or he could be BMI 35 and have a blocked nose. So what do? If we know that they still need to be on CPAP, and I said the best way and the only way to breathe correctly when you're sleeping is through the nose, then we should not be using a full face mask like the picture on the left, but should be using something that really just works on the nose, a nasal mask, or even more comfortable, a nasal pillow. So you can see the picture on the left, the guy's eyes are staring because he's not comfortable. Look at the guy on the right, he's smiling there, he's ready to go, right? Right. So okay, just want to give you some idea of what the inside of the nose is in a cross-section. So we talked about the green part is the airway that you need to breathe. If a turbinate is big, take care of that. If a septum is deviated, there is no medical treatment for that. If it needs to be straightened out, then you need surgery. So then what do? So this is a side image of this wall, the septum that divides the left nose from the right nose. So in the front, you've got the cartilage. That's why your nose is not stiff. And further back, you get various bones. So when we do the simplest operation for a deviated septum, which is called a septoplasty, we basically want to keep the top and the bottom part of the nose as what we call the L strut. So that's like the pillars and beams of a room. And if you keep that in between, the rest of it doesn't have to be there. So in the diagram on the right side that cut out, essentially that part can be removed and you don't really affect the strength of the nose. Of course, unless if you're doing contact sports, it's a different thing. But just for a normal sedentary person, the nose is not going to fall because of that. And you can actually, this is a patient, a typical patient, a slight septal deviation, a fairly big turbinate on the right side. And if you do surgery, you can make it straighter. You can make that turbinate smaller and look very, very nice. And you can tell this is probably about 3 weeks after surgery because there are still a few red spots still healing away. This patient breathes 100% better, right? And this is what it's like. So this is a septoplasty, can be done from inside the nose. But sometimes we actually have to do a rhinoplasty or a nose job, not for cosmetic reasons primarily, but because the part that's affected is the front, it's the cartilage. And the cartilage is not something where you can just cut away. I've talked about that. We need the structural support. So in order to get to that part of the nose, we often have to make incisions, as the picture on the left shows how it's drawn. Typically, we don't draw a straight line because it becomes too obvious then. And I apologize if you're having lunch and looking at this picture, sorry. Just had to explain this in real life, right? So you can see in a patient that is deviated, and sometimes we need to correct the cartilage. And this is what a scar might look like 3 weeks later. And you can see as well, sometimes without planning to do it, you can actually make the person look better as well, because a nose that is deviated is often collapsed, and you can see the picture from left to right, how we have not just straightened the nose, but actually the side profile and probably the front profile looks better as well. So key points today, we started with sinus because the sinus, or what we describe as sinus, often leads to all these other problems, whether it's allergy, sinusitis. The treatment options are pretty much the same. And if you're thinking long term, obstructive sleep apnea is the next big thing that is going to affect us. And we've got to start thinking from when the patient's a child, because if we do it right, we set them up for success later in life. Okay, thank you very much for your attention today. If you want to ask questions or you want to scan the QR code, you can.